So I'm going to review the paper by Mike April, Massive Transfusion Thresholds Associated with Combat Casualty Mortality During Operations in Afghanistan and Iraq, Implications for the Role 1 Logistical Support Chains, that was recently published in the U.S. Army Medical Journal. Obviously, this is a little more specific to some of my military listeners, but much of the trauma lessons learned from the military are extrapolated out in the civilian setting. In this, we sought to determine what thresholds of blood transfusion is most associated with short-term death. Massive transfusion is frequently referred to as 10 or more units of packed red cells. However, that number is a bit arbitrarily selected by blood bankers back in the days because it had more to do with resource mobilization from their perspective. Whereas there's little data supporting 10 as any kind of magical number, at which point mortality starts to increase or decrease. In the data set, we had 2,600 casualties that received at least one unit of packed red cells or whole blood. We constructed a whole bunch of receiver operating characteristics to find Newton's index, as well as find the optimal balance of sensitivity and specificity for death. And alternatively, we also sought to determine where the 90% sensitivity threshold occurred in terms of number of units of blood at death. We found that Newton's index, which balances the sensitivity and specificity, was at 20 units versus 90% sensitivity for death was at 2 units. This data suggests that as low as 2 units, we need to consider mobilizing additional resources, but the highest risk of death likely exceeds 10 units. So what this take-home point of this is that we need a little more data to help guide resource mobilization when it comes to these real sick trauma patients. Let me know your thoughts in the comments.